Ladies and gentlemen, thank you for being with us in this Jafron-sponsored symposium. So we have about an hour to discuss hemoadsorption in different settings in the critical care patients. I'm very thankful of Jafron for organizing this symposium, giving us the opportunity to discuss this matter. And we have three great speakers here that will entertain us and inform us about hemoadsorption in critical ill patients in general, in sepsis, and how to manage vasoplegic shock in general. And of course, the place of this therapy will be investigated. So we have three presentations of 15 minutes, followed by 10 minutes discussion, and I encourage you to use your app and your smartphone to ask questions that then you can store somewhere, and I can ask the speakers the questions. If you don't want to, of course, at the end, you're still welcome to ask the question in real life. So I've got a few minutes to introduce the speakers. It's my great pleasure again to welcome them to this symposium. So the first speaker is not me. This is the chair. So my name is Antoine Schneider. I should have started with this. I'm an intensivist from Lausanne, Switzerland, and I'm going to be moderating the session. The first speaker is Dr. Fernando Sanchez Moran. He's an intensivist from Castellón, Spain. He's interested in acute renal failure, CRT, sepsis, and septic shock, and he will talk to us about how to perform hemoperfusion in critically ill patients. Our next speaker comes from Turkey, Dr. Okay Demirkarian, and he's an intensivist from Turkey, from Istanbul University. He's a professor of anesthesiology, is member of the Turkish Society and of many other societies, including the European Society of Intensive Care, and he will talk to us about hemoperfusion in critically ill patients, in sepsis, sorry. And the last and third speaker is Dr. Sandeep Kaul from London. He's also a very interested specialist in critical care and respiratory medicine, and he will discuss a bit broader topic on vasoplegic shock and how to manage these patients. So without any further delay, I welcome our first speaker to come to stage and start with the first presentation. And again, prepare your questions for the discussion. Thank you very much.
Thank you very much, Dr. Schneider, for your kind presentation. And I would also like to thank our friends from Jafron to organize this symposium. And now we're moving on to the presentation, and we're trying we will try to answer or to see what hemoperfusion can offer us in the setting of the critical patients. Hemoperfusion is a blood purification technique. We know this technique from long ago, and contrary to the conventional blood purification techniques, to convention and diffusion, this technique is based in absorption. It is also known as hemoadsorption, and is basically used in the removal of toxins in poisoning and in cytokines in septic and inflamed patients. We have different devices available in the market. There are some of them they are built as fibers, other are as beds, granules, or other forms, and all of them, as it is a very versatile technique, it can be used as a standalone therapy or combined with conventional renal replacement therapies, and even associated with cardiopulmonary bypass. Regarding the mechanism of absorption, this mechanism it works in different steps. I think it is important to know what this technique, how this technique works, and knowing this, perhaps we will be able to imagine the settings in which it will be useful. In the first phase of this absorption, the toxin is bulked from the fluid to the outer surface of the absorber, and followed by a diffusive movement from this outer surface of the absorber to the internal part of the porus. In a different phase, this will be followed by a binding. Different binding mechanism, fundamental based in ionic and van der Waals forces, but the main mechanism is based on the hydrophobicity. There are not specific indications of hemoperfusion in the critically ill patient, but in the recent years, there have emerged different indications that in these few minutes we are going to have a quick look. Perhaps the use of hemoabsorption in poisoning is the most widely spread indication, at least in the past years. All the information we have from this indication is based in retrospective studies, so the information we can extract from this is quite limited. For example, we have this study about paraquat poisoning, and it was made in 4 centers, and patients were allocated into 3 different groups: conventional therapy, or a second group associated to hemoperfusion, and a third group where they combine hemoperfusion and CPBH. What they got in the results was that the levels of paraquat at 72 hours after the initiation of the treatment were lower in patients with hemoperfusion or hemoperfusion combined with renal replacement therapies. Also, there was a significant improvement in the SOFA score in patients treated with these 2 kinds of therapies. What we can extract from this study is that in certain type of poisonings, hemoperfusion can offer a quicker elimination of the toxin when it's associated to conventional removal therapies. Also, all these findings they were accompanied by an improvement in survival in these 2 groups. But even if it is the most recognized indication, what we can see is that even when it is indicated, there is a very low use of this therapy when it could have played a role in the treatment of certain patients. Regarding the liver disease, it sounds quite logic to think about this therapy, and during the past years there have emerged different kind of liver depuration systems, and it's a therapy that we don't have we don't have a lot of data to set a recommendation, but it's a therapy that in these years it might be a promising therapy. One of the fields that has emerged with power in the last years is the potential role of hemoperfusion in those situations with systemic hyperinflammation, like IRDS, pancreatitis, cardiac surgery, major burns, or sepsis. And we are going to have a look through a few of them. About IRDS, unfortunately, most of the studies have failed in proving an effective reduction of cytokines between patients treated with hemoperfusion and conventional therapy. Perhaps in these studies, it's quite logical to think that perhaps there is a problem in the selection of the patients and in the selection of the initiation of the therapy. As far as we know, the dynamics of cytokines, it is important to start the therapy when the levels are high and when they might be correlated with the clinical state. So some studies perhaps they have a bias in this about this. Other studies have tried to study the effect of hemoperfusion combined with ECMO, and we have all kinds of results, from those who couldn't prove any benefit and those who find some benefits more related with improvement in hemodynamics or respiratory parameters more than in mortality. But the main problem of most of them is that they don't provide a single measurement of interleukins. And when we are talking about a technology based on elimination of certain molecules, if we don't measure what we say we are trying to eliminate, it's quite limited the conclusion that we can extract from the study. Other studies, they have found effectiveness in the reduction of interleukin levels, but when they compare the results in the group where they patients treated with hemoperfusion, they find that in that group of patients they could divide it in two groups: the ones who improve and the ones who didn't improve anything. They found differences between the group of patients treated and not treated, but they couldn't find significant difference between the patients treated with hemoperfusion who improve and patients treated with hemoperfusion without any improvement. And we also can find studies with incredible results, but without providing any single measure of cytokines. The conclusions that can be drawn from these studies, they are very, very limited. About cardiac surgery, it's a field that has been explored largely with hemoperfusion, and finding a good correlation with improvement on mortality is difficult to find. Perhaps it is not the right outcome to measure in this kind of patient. We have several studies that they have shown that other clinical outcomes can be possible and they are important to measure. For example, the doses of cytokines the doses of vasopressors, they are correlated to the levels of cytokines, and it was also related to the length of stay in ICU and the days of mechanical ventilation. And regarding sepsis, it's not easy to talk about the role of hemoperfusion after the publication 1 year ago of the recommendation of the Surviving Sepsis campaign, where they said that hemoperfusion with polymyxin B, it wasn't. They didn't recommend the use of polymyxin B as a treatment in septic patients. It is. We can debate about this for long, but there's a second part in that recommendation that, or where they said that they couldn't recommend anything or couldn't set any recommendation about other blood purification techniques, that including other devices. Here I bring two. I think there are interesting studies from Dr. Sao. They are very well conducted studies. They are prospective randomized studies with more or less the same scheme of treatment, where patients were allocated to conventional treatment or conventional treatment plus hemoperfusion. In this one, they measure IL-6 and IL-8, and they proved that hemoperfusion was effective in the reduction of these mediators. One of the problems of this study is that the population is quite heterogeneous. We have abdominal sepsis, respiratory sepsis, and other kind of sources of infection. But in all of them, what they found, there was a significant reduction in patients treated with hemoperfusion. And they also warned us about the possible side effect, like the drop in the platelet count. A second study, in this case with respiratory sepsis, here in this case they measure TNF and IL-1. The scheme of treatment, it was the same, and they found improvement in respiratory parameters and hemodynamics, and this was correlated also with less duration of mechanical ventilation, of renal support, lower length of stay in ICU, and lower mortality. I think that are quite good results. But one thing that we must take in account is that not all sepsis are the same. And what I mean is that even there might be a potential role of this therapy in sepsis, it doesn't mean that it is for all septic patients. Because one thing that we learned from the definition of sepsis given by the last consensus conference on sepsis is that the problem is not the infection itself, it's how the patient react to the infection. And the main thing is that there's a dysregulation on the host response. So it's something that we must take in account, that the same infection in two different patients is not the same. And related to that, we know that all infections have different patterns. Not all infections have the same inflammatory degree. And in this line, in this line, we know that, for example, abdominal sepsis has higher inflammation pattern, and also is accompanied with more coagulation disorders, more activation of complement, more oxidative stress, and of course more cellular damage and death. So to know which kind of patient is appropriate for this therapy, we are in the right time to conduct rigorous and serious studies to identify which patient could benefit most from this therapy. This is mandatory. For this, it's mandatory to select an homogeneous population, trying to enrich the sample with clinical criteria, also biomarkers, and perhaps including a genomical approach to select the right population to conduct the study, and trying to find optimal endpoints at the beginning, probably related to levels of cytokines and other outcomes, and finally translating these results into clinical endpoints. I would like to give a brief comment about our experience with this technology. We are very restrictive using this technology. We restrict its use to abdominal sepsis with patients with this criteria, and we follow this scheme of treatment. We consider up to 4 cartridges, but usually we don't go beyond the second, because the improvement of the patient and the measurement of inflammation. For in the last 2 years, we have received 45 patients with abdominal sepsis. Only 9 of them meet the clinical criteria and the basic parameters of biomarkers. I mean, procalcitonin and RCP. And when they meet this criteria, we measure IL-6. From these 45, only 9 meet the criteria, and only 5 have an interleukin-6 levels above 2,000. Our experience with these patients, as I said, is quite good. All these patients, they are still alive. We have seen a dramatic drop of the doses of vasopressors following the reduction of IL-6. And clinically, what we see is an improvement of the signs of hypoperfusion, and it's quite spectacular sometimes. But we have also seen what other authors confirm in their study, that there is a dramatic drop in platelets and a trend to lower in albumin. But both, they recover after the interruption of the therapy. Just to finish, we are in a time that we are facing an exciting challenge, like defining the role of this therapy in critically ill patients. We have to define which patient is suitable for this therapy. We have to search for the right indication, the right moment, the right duration of this therapy, how to follow the result of the therapy, which is the most suitable biomarker for this, and all the potential side effects of this. As a conclusion, there's only one accepted indication for this therapy, and although it's accepted, it's poorly used. We have current low level of evidence supporting this therapy. We don't even know how it really works, but it seems that it's a technology that is effective, reducing the levels of cytokines. But if we use this therapy with this objective, it should be carefully monitored. And to finish, we need a specific criteria to define the usage of this therapy. Thank you very much.
Thank you very much for this very nice presentation. In the interest of time, we're going to move to the next speaker, Dr. Demir Kerian from Turkey again. I encourage you, while the speaker is getting ready, to ask the questions via the chat, so we can get prepared for the discussion at the end of the presentation. The floor is yours.
Thank you, dear President, ladies and gentlemen, and the Jafron to invite me here. Thank you very much. My topic is the application of hemoperfusion in sepsis. Sorry about some overlap slides with the previous speaker, but it's unexpected for that, and we need more studies, and then some slides may be same. In my talk, I'll tell you briefly about the pathophysiology of sepsis and the indications in ICU and the hemoadsorption, what's it, and the hemoadsorption using sepsis. The definition is the key point that the complex clinical and biological syndrome defined as life-threatening organ dysfunction caused by dysregulated host response to infection. Because of that, the new therapies have been developed as for address certain steps of this immune dysregulation. If you look at the pathophysiology very briefly, the host and pathogen interaction is important. When it starts, there are two arms, that the pro-inflammatory response or anti-inflammatory response. In pro-inflammatory response, there is excessive inflammation and causing to tissue damage. At the anti-inflammatory phase, there is high susceptible to secondary infection due to immunosuppression. In the pro-inflammatory phase, the PAPs and DAMs affect the system, and they induce leukocytes, and because of the activation of leukocytes, there is complement activation, there is coagulation cascade activation. At the other side, there is impaired immune cell function, which causes impaired phagocytosis or maturation defects, and it causes apoptosis in the cells. The immune response in sepsis is excessive and unbalanced host immune response, and that's why we have to do something for this and stop in any time any steps in sepsis to be successful to treat sepsis. The DAMs and PAMs activated neutrophil, and then they cause the release cytokines. The inflammatory and anti-inflammatory cytokines releasing. If it's excessive, it's called cytokine storm, and it causes immune suppression and also organ-related dysfunctions, like in brain, sepsis-induced encephalopathy. In the vascular system, the vascular hyperpermeability causes glycocalyx disruption, impaired cell-to-cell junction. Also in heart, cardiomyopathy or impaired tissue oxygen metabolism, and causes microvascular system disorders. There's a vicious cycle that due to DAMs and dysregulated immune response, the cell death, tissue injury, apoptosis, and DAMs, the high mobility GOL-BAX1 protein increases, and then the DAMs effect again and again, the circus vicious is going on. And if you look at the immune steps or events in sepsis, there is also a possibility effects of the gram-negative and gram-positive results, and they cause at the end microvascular occlusion and vascular instability, and the end point is that the coagulopathy, fever, vasodilation, and capillary leakage, and it causes sepsis and multiple organ failure. If you look at the right side, the hyperinflammation and immune suppression is very important, and then early that you can see that in the early phase, due to initial intense inflammatory response is 10%. If you can affect here, if you restore the hemostasis, and the recovery is up to 60%. That's why important, I will tell in my forward slides also again. And the blood purification targets are removing the pathogens from the blood. The second point says removing endotoxins or other PAMs, and removing leukocytes and reprogramming leukocytes, or reducing cytokines in blood levels. This cytokine absorption is important, and as you see here, how can I use the touch laser here? Okay, no? Okay, the pro-inflammatory cytokines, TNF-alpha, IL-1, IL-6, IL-8, okay, thank you. Here, and the indications for hematabsorption in ICU are sepsis, intoxications, hepatic failure, the non-infection hyperinflammatory phases like conditions, trauma, pancreatitis, burn, or rheumatological disorders. My topic is specifically for sepsis, and I will talk for this sepsis now. The different mass separation processes are diffusion in hemodialysis, we know that, the convection in hemofiltration or hemodiafiltration, and the solute absorption, the mass separation by solid agents like sorbents, we can use it. And the sorbents are very large surface volume ratio and the significant capacity to bind specific solutes like with weak ionic bonds, the van der Waals forces, or strong hydrophobic bonds, and they produced in granules, beads, or fibers. The hemoperfusion in sepsis can be selective or non-selective treatment. The selective treatment is selecting the targeting the key molecule special for endotoxin. Mainly, extracorporeal treatment is an adjuvant therapy. It's a rescue therapy. It's a salvage therapy in sepsis. And the main goal of constructing an optimal sorbent cartridge is to obtain the maximum contact of the fluid phase with the entire amount of the available sorbent. There are three phases is that here, as you see here, in the interparticle phase, the blood flow through the tortuous pathway. In the interphase phase, the blood flow on the external surface of the bead, and the intraphase part is the blood flow on the internal part of the bead. The current available technologies are here. As you see, there are sorbent polymer differences in there. There is Nordic charcoal, polymyxin B, spherical charcoal, or polystyrene divinyl benzene, or ultra-high molecular weight polyethylene beads with end point attached heparin. They are all different each other. And the cytokine in sepsis is important. The profile, if we check this, the IL-6 and organ dysfunction is very with an interaction. And if you look at the in Kuma study, the IL-6 in survivors and non-survivors, the right side is for male and the left side is a female. In male and female, in survivors, the IL-6 level decrease, and in non-survivors, there is no change or they increase. And another study in Tchaikovsky study, the procalcitonin, interleukin, and CRP levels are very high in non-survivors due to sepsis. There is selective hemoperfusion with a fiber column immobilized with polymyxin B. And in this trial, the A-phase trial in 2019 with 64 patients in septic shock due to intra-abdominal gram-negative infection, and 34 patients used polymyxin B, 30 not, and improvements of the hemodynamics, respiratory function, sepsis-related organ scores, and mortality in treatment group. And there is also a decrease in 28-day mortality from 53 to 28. But the second study with more patients, 450 patients in septic shock with increased high level endotoxin, the polymyxin hemoperfusion for 90 and 120 minutes, the polymyxin hemoperfusion did not show any significant reduce in mortality in that study. In non-selective hemadsorption, as mentioned before in the previous speaker, there is sorbent, we use hemodiafilter, and we have opportunities to use alone the sorbents or combine with the CRRT or ECMO to use together for effectiveness. In this study, there is cytokine elimination for rescue therapy, 20 patients with refractory septic shock. In conventional therapy, the lactate increase and the high dose vasopressor necessary noradrenaline 0.3 microgram per kilogram per minute. 6 hours after conventional therapy, there is hypercytokinemia, and IL-6 level is high in that group, and the hemoperfusion treatment initiated approximately in 8 hours after the shock treatment. And when you look at the noradrenaline requirement, it decreased with the hemoperfusion use, and the lactate clearance increased in that patients. And another study here, the cytokine elimination causes the shock reversal, and 28-day mortality is 45%. In Jafron neutral-microporous resin, which is string divinyl benzene copolymer, there are 3 different types, and HA130, 230, or 330, 380. There are different indications. In 330, it's my topic now with sepsis, the acute conditions with cytokine storm such as sepsis, we use it, and the molecular weight removed is 10 to 60 kilodalton, and the resin pore size distribution is 500 dalton to 60 kilodalton. The toxins removed here, the cytokines complements removed by this 330. If you look at this, the electron microscopy results here, the beads, the surface of the beads at the middle, and the pores you can see. In that study, in 3 septic children, they use HA330, 4-hour treatment with 330, and they found that the IL-6 level decreased here, as you see, very, very significantly decreasing. Huang study for 44 patients, 24 patient treatment group and 24 control group, they use HA330, and the etiology of infections are mostly abdominal, the microorganism gram-negative bacteria mostly. And in that group, you see that the dose of dopamine, dobutamine, and noradrenaline use decreased in HA330 group. And if you look at the IL-6 levels here, IL-6 levels decreased in HA group here, and no significant difference or decrease in control group. This in this study also we can see the ICU mortality is significantly reduced in the HA hemoperfusion group when we compare with the control group, and the hospital mortality decreased in the hemoperfusion group. The same authors has another study 3 years later published with 46 patients in sepsis and acute lung injury patients, and they use HA330 versus usual care. This is for 3 days treatment, and in that study, IL-1, TNF-alpha, and levels decreased in plasma and in bronchoalveolar lavage control, and also dopamine, noradrenaline requirement decreased in hemoperfusion group. And also ICU mortality and 28-day mortality has difference in hemoperfusion group in that study. This is the comparison of the 2 studies with the same study group here. And this is another study by Chu, 30 patients in septic shock. They use hemoperfusion with pulse high volume hemofiltration. And the other group is only with continuous venous hemofiltration. They compared this T group in hemoperfusion with high volume, pulse high volume hemofiltration. There is a significant decrease in procalcitonin, Apache 3, and decrease in SOFA score. It means it's better condition in the patients, and also IL-6, TNF-alpha, and IL-10 levels decrease in the first group. This is another study from Turkey. This is the first study in Turkey, 2019. They used, for 11 patients with high-dose vasopressor organ, and they found that the hemoperfusion group, the CRP and procalcitonin level decreased. This is the case report for 78 male patient, fecal peritonitis in septic shock. In this patient, they saw that the noradrenaline use decreased, blood pressure increased. This is our case, one of our case, 31 years old female. She had bariatric surgery. In the post-operative 7th day, she had septic shock due to surgical problem. There is source control for reoperation, and we saw that there is a leakage. And at the 3rd day ICU admission, we used H8330, and she became in a good condition, but 20 days later, due to induced pneumonia, she had another septic shock attack, and we used again the hemoperfusion, and we have the same results, decrease in noradrenaline use and increase in blood pressure. At the end we are very happy because she's well and discharged from ICU. I skipped this, and in septic shock patient, if there is refractory septic shock, multi-organ dysfunction, we can use high endotoxin activity. If there is hypercytokinemia, we can use consider cytokine absorption. And the important point is that in sepsis, the timing, when we have to start to use it, I think that this is domino effect. If you couldn't stop it at the beginning, you can't stop to drop all the domino stones. Because of that, you have to do this in this phase, earlier phase, to restore the organ perfusion. In sepsis guideline, it says that there is insufficient evidence. We have to improve the data for this. For the future research, defining the adequate dose, optimal dose, and safety results. This is my last slide. For this. Hemoadsorption is a salvage therapy. It's a rescue therapy. It's not definitive therapy. You have to do everything for this patient, and you can use it. But most important point is right time, right patient, and right screening conditions. I couldn't do this for this movie. Okay, slide videos.
Thank you very much.
Thank you.
So thank you very much for this presentation. I'm calling the last speaker, Sanjib Kaur from London again, to talk about how to manage vasoplegia in, I guess, in critical ill patients. And I encourage you again to ask questions. I think we have minimal time for the discussion, but that would be nice to have 1 or 2 questions on your side, or if you can use the microphone if you prefer.
Chairman, colleagues, and Jafron, thank you very much for the opportunity of sharing a few thoughts and ideas this afternoon. I promise to be quick. My colleagues already have presented fantastic data, have done all the hard work, so I can actually finish very quickly. And by the way, before today, I hadn't met my colleagues before, so you can see this is obviously marriage made in heaven. So very quickly, and I promise to be pretty swift about this, what is the issue in terms of vasoplegia? I'll just define it very quickly. What the current options are. Our personal experience I'll spend a few minutes on, and then what I think are next steps for the future, and a lot of them will be married by colleagues today. Issue for me as a clinician, as a intensive care doctor who sits in the hospital and then gets called at night, what is the problem? The problem is is vasodilatory shock. It is a state of hyperperfusion. There is low SVR, there is decreased vasomotor tone, and of course it has multifactorial etiologies, whether it's sepsis, whether it's post-pulmonary bypass, cardiopulmonary bypass, as I'll mention in a minute, whether it's trauma, burns, poisoning, etc. That is the end point of what I see, and that is what I'm faced with when I'm sitting there in the ICU. It has multiple, if you like, variations on a definition. I hope you recognize these. But what I want to bring to your attention is normal or reduced central filling pressures. How do you actually standardize for that? I think it's really important. We can probably agree on a lot of the other stuff, but things like vasopressors and normalizing filling pressures, how do you actually standardize for that in the intensive care? Do we all have agreement, if you like, on what that is and how you measure it? For one, we use a PA catheter. That's not everybody's cup of tea is what I'm getting at. So there's various standardizations which I think are important. I make a special mention for cardiopulmonary bypass. I work in a cardiac center. And this affects a lot of patients. This keeps me up every week, at least once a week, okay? So my poor sleep isn't because of my 3 children. It is because of high lactemia and, high vasopressor requirement. My kids, bless them, I changed the nappy. That doesn't keep me up, though. So a lot of these people require large amounts of vasopressor, whether it's NORAD, whether it's dopamine you guys use, or adrenaline, or vasopressin, doesn't matter. It's a high amount. It's escalating. And we know post-bypass, these people have a high mortality and high morbidity. Who do I pick that I know this is going to happen in? The people who have had a longer bypass time. Not just the transplants. I mean normal, just cabbage, just AVR plus cabbage, just MVR plus cabbage, plus MVR, TVR plus cabbage. I mean, as many variations as my surgeons can do for me, And the longer they spend there, then the one with the core temperature on bypass, the longer the duration of the bypass, the more the right heart failure, the more vasoplegia. You know what the game is. The people who've had pre-op antihypertensive medications, and if people have got COPD or somebody's inflamed with bronchiectasis and got pseudomonas somewhere, you can expect that some mischief is going to happen a bit later on. What do we mean by refractory? I don't know, actually. Does that mean refractory to conventional dose NORAD and vasopressin? Does that mean refractory to steroids? Does that mean refractory to methylene blue? Does that mean we now got angiotensin 2? I haven't used it yet, but it's out there. What does it mean? We need some agreement on that. And then what are the options? At the moment, this is what I have. I don't have IL-6. I'm not as blessed as Fernando and as other colleagues who have IL-6 at the bedside. I don't have this, but I have high-dose noradrenaline. I hope I have angiotensin 2. I use methylene blue, and of course I've used extracorporeal blood purification. And a few thoughts on that today in terms of our experience. We looked at our 5-year usage of methylene blue and after post-cardiac surgery and refractory shock. And we have 125 patients in this group, so it's purely an audit at this point. Almost 100 are in the intensive care and 28 in theatre. Forget the 4 lovely people who are in recovery. They came to ICU anyway. Everybody comes to ICU finally. When stops go off, they all come to intensive care. So that's fine. But what I wanted to share with you was that 62% of those people who in the ICU post-cardiac surgery were post-cardio bypass, pulmonary bypass, and about a third had sepsis, roughly. 2/3 had low filling pressures. And that is in a unit which measures with PA catheter and echo. So I don't know what's happening in the places that you don't use it. I've no idea. But 2/3 had low filling pressures, so you want to get it up. We used methylene blue at 2 milligrams per kilogram in most people, and a quarter required a second dose. Yes, 13% it was contraindicated, who cares? We have to save the life. But interestingly, what was the survival? All comers was 38% in our 5-year group. Of those people who got methylene blue, just over a third made it out the unit. And there's a group that you can't see, unfortunately, I don't know why, but that's post-lung transplant. This group here is post-lung transplant. And 71% of those people made it out of the unit. So it's an interesting group. So that leads me on to extracorporeal blood purification. You know what it is. I'm not going to bore you with it because you've heard it in better detail than I can describe. But what I do want to say is that there seems to be an increasing practice. Definitely, I'm interested. And the rationale is very straightforward. However, there's still doubt because as you've heard very eloquently, the long-term outcomes of these patients have yet to determine consistent results in terms of survival. The other thing is, it's not one condition. Sepsis, as you heard, is heterogeneous. And I was describing this to a colleague earlier. It's like going to a wedding. At the wedding, if I'm the father of the bride, I'm the main man. Okay? So in cardiopulmonary bypass, maybe this is the treatment. Maybe extracorporeal blood purification is the main man. Maybe it traverses you past the eye of the storm and you're better again. When it comes to sepsis, I'm the brother-in-law. So if I don't turn up, I don't turn up. If I do, I do. And actually, the father of the bride, the mother of the bride, the bridegroom, everybody else needs to be there as well and do their part, otherwise this whole thing goes down the tubes. So I'm part of the process, I'm not all of it. And that role is really important to define in what setting, what is the function of this whole process. So we've used Cytazorb, we've used Oxiris, we've used HA330, we've just started using 380, and I'm just going to share some unpublished, raw, uncontrolled, real-life data, which keeps me up at night. So this is the vasoplegia, high vasopressor requirement. This is the hyperlactemic group, not everybody, but some of them. And this is in the context of post-bypass SIRS or sepsis. Those are the 18 patients I'm going to share with you. As you'll see, most of them are post-bypass. We've got a post-lung transplant with ECMO. I've got a post-VATS empyema. But on the whole, a lot of it is post-CABG, post-MVR, TVR, decompensated DCM with sepsis, post-AVR, MVR, etc. So there's a fair mixture there. I'm going to share with you the lactate change in 24 hours, the mean time to reduction in lactate in a 50% reduction, the vasopressor reduction, the mean duration of our intervention, and the 72-hour ICU survival, and then the crude ICU mortality. The caveat, not everybody had a high lactate, and I'll do that separately. So in this 18, the mean lactate at the beginning was 4.65. You might say, hey, that's not very high. Maybe you're right. At 24 hours, it had dropped to 2.5. And so roughly, it took about 25 hours to get a 50% reduction in the lactate in the whole lot. In terms of noradrenaline, by 48 hours, it was under half, although it was close to half. Basically, it takes about 39 hours to get a 50% reduction. Interestingly, in 2 patients, the vasopressor requirement went up, not down. The vasopressin reduction was 50% in 48 hours. Much easier to define, interestingly. And the mean duration of our HA330 was 34 hours. It's a mean. It's not obviously, I haven't given you the ranges. 72-hour ICU survival is 94%. But look at that. At discharge, it's 50%. That's a long drop, isn't it, from 94 to 50? So there's got to be something there that's missing. That's why I say I'm not the father of the bride in that one. I'm the brother-in-law. Something isn't quite right. Here's the hyperlactemic group. And you'll see most of these are post-bypass. I've got an out-of-hospital cardiac arrest, okay? But most of these, and a lung transplant, most of these are hyperlactemic. These are. N equals 9. So this time, the mean time to produce a 50% reduction in the lactate is 11 hours versus 25. The mean time to achieve 50% reduction in NORAD is 34 versus 39. You might say, hey, not a massive amount. In terms of vasopressin, at 48 hours, 64% reduction in vasopressin. So almost 2/3. It seems more sensitive, doesn't it? And my use duration of HA330 was slightly less by a few hours, nothing major, about almost 29, 30 hours. 72 ICU survival, 72-hour ICU was 100%. But look at the discharge. The survival at discharge is 44%. There's more to this game than meets the eye. So I can't make any claims here. It's all hypothesis generating. Of course it needs an RCT, and I'm very keen to do one. And I'm going to very much reiterate what my colleagues, and indeed learned colleagues, have said over the whole day today. We need to move from the observational to the RCT. Yes, of course, there's fantastic post-hoc analysis. Use it. Let's pick up those signals and do something with them. We need a more targeted focus. We need to go with etiology. And yes, appropriate patient selection. And according to etiology for me, the threshold. When do we go? Is it after steroids? Is it before methylene blue? How long do we use the cartridge for? What is the duration of the treatment? What's the dose? Are they filled? Are patients adequately filled? How do you know? I know how I know. I put the PA catheter in, I measured it all. Okay, so I know how I know. Echo, no tamponade. Biventricular failure, normal ventricular failure. What's going on here? I know. I'm lucky. I have friends who'll do it for me. Okay? Because the surgeon will go, oh, patient's fine when I left him. You know, that's okay, but when I put the TOE down, the RV looks like this. It's not great, you know. So that's really important. Have we taken into account the confounders? Hemoglobin, fluid balance, effluent dose, duration. And of course, you've got other rescue therapies that can muddy the water, whether it's angiotensin 2 or methylene blue, whatever else you use. We must never forget that this whole syndrome can be confounded by other mimickers. Tamponade, in my case, is a big one, but you need to be aware of it. Each vasoplesic syndrome has its own natural history. In the case of abdominal sepsis, it could be you need a surgeon. Okay? It could be you don't need a surgeon. If you do, it's a big player. You need a good surgeon. You know? If it's pneumonia, if it's chest infection, is this abscess where the guy needs a drain? Or is it ventilation, hemodynamics, and antibiotics that are doing all the main heavy lifting? Everything's a bit different. So they have common outcomes, which of course are survival, length of stay, renal failure, etc. But then they have specific outcomes to that particular etiology. So we need to evolve from cytokine-based endpoints, and I'm not saying leave them, they need to be hand in hand, because as you heard my colleague say, if I don't know what I'm measuring, I don't know when to start. That's the problem. I need a good way of knowing when to start. I need patient-centered metrics, though. They need to be physiology, they need to be financial as well as patient. The safety is crucial, whether it's platelets, whether it's linezolid removal, whether it's complication from high-dose vasopressors, to and fro, pro and cons, you need to have the safety metrics. I need NNT data. The stats has to be really good. And I need to look at endpoints like renal replacement therapy. And, of course, post-sepsis syndrome. It isn't about bye-bye at the door and you've gone. It's what happens to you a year down the line. You can make someone better, but you can reduce their quality of life hugely. I want somebody who is as good as when he came in, if not better. And, of course, all this can influence positioning of any intervention, because depending on what rank you are in the order, you have to produce your study accordingly. So there are multiple ongoing studies, I'm delighted to say. I think 2 years ago I wouldn't be able to say this. And they are across the world, and they are in different organ systems, I'm delighted to note. 380 obviously is replacing 330, and I'm seeing that change as well. And I think this is very, this is encouraging, hugely encouraging. So in summary, I hope I've caught up, Chairman. Refractory vasoplegia remains a common clinical scenario. It carries a significant mortality and morbidity. Our initial clinical experience has been quite encouraging, but it is an uncontrolled cohort, N equals 1 center, and it poses more questions than it answers. Important questions, though. There are prospective studies underway, and that is fantastic to see. But the evolution of the study design is crucial, and the metrics is crucial, because we need to capture and quantify the size of the signal, and that allows us, and you heard from Fernando earlier, you don't know what the host response is going to be. So if I'm going to personalize the treatment, I need to know what that host response is to know whether I'm going to intervene or not. Clearly, it is a multi-stakeholder collaboration, and exciting times are ahead as we begin to finally make a dent in this important condition. Thank you very much indeed.
Thank you very much, Sanjeev. Any questions from the audience? We have 2 minutes. If not, I'm going to ask a question to the 3 speakers and whoever wants to respond. So we have, basically, you've shown us that this is an area of like lots of questions are still open. Lots of research needs to be undertaken. We've seen that in Spain you have this cutoff of 2,000 for IL-6. You use IL-6 because it's available. In Turkey, you tend to use more as a therapy as a last resource. What would be if you had one? If you all had IL-6, would that be your preferred biomarker? Would there be another biomarker? Let's say you can click your finger, you had it at the bedside. Which one would you pick if you could? I know you don't know, but which one would you pick now? Do we have a microphone or no? Oh yeah. Well,
it's really hard to answer to that question. IL-6 is widely spread because perhaps it's the more available cytokine to measure. But we do know that probably it's not the best cytokine to measure. Why we use it in our unit? Because it's the only one our hospital measures, so we have to work with this. If I have to choose one, probably endotoxin, but it's not for all kind of infections and not for all situations. But with one cytokine, probably I will still working with IL-6.
Thank you for your response. I think we have to finish here. I think as a take-home message, we should realize that we have a technology that's now available that is brought to us by the industry, that is made available, that is easily easy to implement in our workflow. We can use them during cardiopulmonary bypass. We can put it in line with a CRT. We still have to determine the timing for initiation, the actual patient that will benefit from these therapies. Again, remember the sepsis guideline recommendation. They did not tell us not to use these therapies. They were just stating that there's not enough data to support or to go against it. So that means we need to provide new data, research, get together, do perhaps registries of everything we've all the therapies we've treated, to improve the knowledge and to really identify those patients that might benefit from the therapy. With that, I would like to thank our three speakers. I would like to thank again Jafron for supporting this symposium and all of you for listening to us this afternoon. Thank you very much and good afternoon.